Hello everyone, this is Dr. Gopi. Today we are going to see session 4 ICU documentation and March chart compliance as a part of ICU nursing orientation program. As per the court of law, if it isn't documented, it didn't happen. We will look into it deeply about why the documentation matters here in this lecture. It is clinical, legal, and quality evidence all in one entry. Clinical communication. It provides shift-to-shift handover, multidisciplinary team alignment, continuity of care across days and weeks among all the clinical updates regarding the patient. It also provides legal protection. Medical record is admissible evidence. If it is not documented, it is equal to not done in court. It protects both the patient and you, and it provides patient safety by giving medication tracking records, allergies, fluid balances, devices used, and it prevents duplications and missed doses. Regarding the audit and accreditation, the NABH assessors review records regularly without fail. The quality indicators like medication errors, fall risks, and hospital-acquired infections are extracted from the documented and reviewed thoroughly during assessment. The learning objectives of this video. To document the ICU flowchart correctly and knowing every sections like vitals, intake output, drugs, ventilator and neuro assessment, lab values, each is being updated in a correct manner. And write structured nursing notes using the DAR or SOAP format and every entry signed, date and timed as per the NABH. Apply the 10 hours of medication administration. Master the rules of safe drug administration and March chart documentation requirements. Comply the NABH 6th edition IMS and MOM updates will be discussed further in this lecture. The anatomy of the ICU flowchart. Every section serves a purpose. Update at a frequency listed. The patient ID strips. It is generated on admission. The patient's UHID is created that includes name, age, sex, diagnosis, allergy, code status, and the consultants involved. The drugs and infusion, each dose and titration is being documented, and also it includes continuous infusions, bolus, drug reactions, and everything is being noted. Regarding the ventilation and oxygen status, fourth hourly or any change is being noted that includes mode, FiO2, PEEP, tidal volume, respiratory rate, peak and plateau pressures, and cuff pressures and ABG times. Regarding the vital signs, it is being noted hourly as per the NEWS 2 guidelines, and heart rate, BP, respiratory rate, saturation, temperature, GCS, MAP, CVP if applicable, and intake output chart that includes total intake and output that includes the entire 24-hour period. All the IV fluids given, drugs given, feeds, food intake and blood transfusion, everything is being calculated in intake. And regarding the drains, NG aspirates, stools, insensible losses and urines, it comes under output chart. In care bundles that includes VAP, CLOPC, COTI, DVT bundles, everything is being checked on shift by shift basis. And also pain, sedation, delirium scores is being maintained. The structured nursing notes. There are two different variations. One is DAR, another one is SOAP. It is preferred based on the hospital norms and SOPs. DAR chart is a focus charting. The D means data, A for action, and R for response. The data includes subjective and objective, what the patient said and what you observed, like vitals and lab reports. In action, the interventions performed, medications given, and escalations made. In response, did it work? Vitals after the intervention, whether it came back to normal, and the follow-up plan. For example, data says the BP of 88 to 52 and drowsy, lactate 3.2. The action is 500 ml NS bolus, doctor informed, and the vasopressor started. In response, that includes BP of 110/68 at 15 minutes, and the patient become more alert and the lactate reduced to 2.4 at 1 hour. In SOAP format, SOAP means subjective, objective, assessment and plan. The subjective is what the patient says or what the family says. Suppose I feel breathless or the pain score is 7 out of 10 in my chest. Objective, vitals, examination findings, labs, imaging and monitoring data. And the assessment part, the ineffective airway clearance, fluid volume deficit, etc. Regarding the plan, the suctioning secondarily or fluid bolus and reassessment in 30 minutes or escalate if no improvement. In NABH 6th edition, the Information Management System chapter requirements includes these 6 major non-negotiable factors. The unique identifier. Every patient gets a unique UHID used on every page and every entry. 2 identifier rule before any intervention. Regarding the authorized entries only parameter allows only the authorized staff making the entries. Hospital policy defines who is the authorized and who is not authorized. And trainees countersigned by qualified staffs. And record contents defined. Regarding commitment, must includes admission details, assessment, consultations, investigation results, care plans, and progress notes. Complete chronological record. Entries in sequential time order with page numbering, no gaps, no backdating, and no erasing. Strike through with the initial if you want to remove anything. And sign date timed commitment. So every entry and every notes, vitals, drugs given has the signature that includes date and time. The single most audited item is signed, date and timed properly or not. Next, the prescription minimum requirements that includes patient name, UHID, drug name, strength, dose, route, frequency, duration, and the prescriber's signature. The 24 hours intake output chart. Accurate intake output drives fluid management, drug dosing, renal monitoring. There is no shortcuts for this. You just have to keep your eye on the patient. Intake, whatever we are giving in to the patient, that includes intake. For example, IV fluids, bolus maintenance, type of fluids and volume involved, the IV drugs along with volumes, the blood and blood products, enteral feeds, flushes, that includes NS or water syringes, and oral intake if applicable, and TPN if provided. In output column, whatever is coming out of the patient, you just record it, like urine output, nasogastric aspiration, drain output, stool, the quantity of the stool, vomiting, even blood loss. So end of shift total will be made on both intake and output chart, and the current balance includes total intake minus total output. If the intake is more than output, it is positive balance. Flag if the positive balance is more than 1 liter without any indication. Regarding the 10 hours of safe medication administration, choosing the right patient, 2 identifiers must be checked, like name and UHID. Check the wristband and verbal confirmation. The right dose, calculate the right dose, then double check. High alert drugs require independent second check as well. The right time, on schedule, document actual time of administration, not just the scheduled slot. The right reason, know why this drug is being given. Question if it doesn't match the diagnosis. Right to refuse, the patient can refuse. Document refusal, inform doctor and do not coerce. Right drug, read label 3 items, pick up, prepare, administer, and beware of LASA drugs, look-alike, sound-alike drugs. The right route, IV, PO, IM, subcutical, and nasogastric route, intrathecal route needs to be clearly documented. Wrong route can kill. Right administration, single MAR chart immediately after giving. Never pre-sign or never delay the signature. The right response, monitored for therapeutic effect and adverse action. The document outcome, the right education, patient, family informed about the drug, purpose and side effects. The NABH 6th edition medication management chapter, these are all the new factors. The medication safety officer. Every accredited hospital must designate an MSO, medication safety officer, to lead medication safety initiatives, error reporting, ADR monitoring, and stewardship. The digital prescription encourages CPOE, computerized physician order entry, to reduce errors from illegible handwriting and missed components. And tighter high alert controls, strict rules on high alert medications, narcotics, chemotherapy, and radiopharmaceuticals. Independent double check and locked storage is necessary. And antimicrobial stewardship training. All clinical staff, that includes staff nurse, must complete training in antimicrobial stewardship. It reflects the shift from the change of antibiotics to antimicrobials. Regarding the high alert medications and double check rules, these drugs can kill if wrong. The list is very important. Every ICU staff should know this. High alert drugs in ICU are insulin, heparin, and anticoagulants, concentrated electrolytes like KCl, sodium chloride, 3% saline, and opioids like morphine, fentanyl, and vasopressors like noradrenaline, adrenaline, neuromuscular blockers, sedatives like propofol, midazolam, and dexmedetomidine, and chemotherapeutic drug. And also includes LASA drugs, look-alike and sound-alike drugs, for example, dopamine and dobutamine, etc. The independent double check. So, two qualified nurses independently read the prescription. Don't repeat what the first nurse says blindly. Verify the dose, drug, and concentration and rate. Calculate independently. Do not share the math. Both should sign the MAR chart. Why independent? If nurse 2 just confirms nurse 1's calculation, both make the same error. Independent checking catches errors, a shared check misses. When required, insulin, heparin, chemo, pediatric doses, neonatal drugs, neuromuscular blocking agents, high alert infusions, and any drug in hospital policy specifies. The common documentation errors. If an NABH assessor opens your chart, these are the things they look for. The pre-signed for drugs not yet given. So you should always sign the MAR chart only after the drug enters the patient. Pre-signing is a fraud. Copying yesterday's vitals or notes. Each entry is independent. Identical number across shifts, documentation fraud. So a big red flag. The missing entry for high alert drug. Every high alert drug needs entry plus second nurse signature plus monitoring response. No exceptions. Erasing or whiting out errors. Strike through with a single line. Write error and initial. Write the correction next to it. So no need to erase or whiting out. Using non-standard abbreviations. Do not use list. Write units, not U. Micrograms, not microgram. Avoid trailing 0. Backdating entries hours later. Document in real time at the bedside. If late, write late entry with correct time and explain. So these are the key takeaways from session 4. Document at the bedside in real time. Every entry signed, date, and timed. 2 identifiers rule for every drug, every procedure, and every transfusion. Apply the 10 hours. Sign the MAR chart after administration, never before. High alert drugs needs independent double check by 2 qualified nurses and calculates separately. The NABH 6th edition introduces the medication safety officer and pushes digital prescriptions. Errors, strike through plus initial plus do the correction. Never erase or white out, and never backdate and never copy paste. So as usual, this is the 4 MCQs from the current session that we are discussing now. Please pause your videos and I will be looking forward to check your answers in the comment section. Thank you. If there is any questions or if you want any discussions, please post in the comment box. Regarding session 5, patient safety, ID, falls, pressure, injury, and restraints will be discussed in the next session. Thank you. Bye.